All right, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic tonight are old diseases and new drugs, a neuro-ophthalmologist perspective. And with us to give this information is Dr. Leo Scorin, who is a consultant in the Department of Surgery, Community Division of Ophthalmology at the Mayo Clinic Health System in Albert Lea in Austin, Minnesota. And he's an assistant professor of ophthalmology at the Mayo Clinic College of Medicine and Science in Rochester, Minnesota. He completed his optometry degree at the Illinois College of Optometry and his osteopathic medical degree at the Chicago College of Osteopathic Medicine. He did his osteopathic medical surgical internship in Tulsa, Oklahoma, and his ophthalmology residency at Michigan State University Metropolitan Hospital. He further did a neuro-ophthalmology fellowship at the University of Illinois Eye and Ear Infirmary, and he has lectured nationally, internationally, published numerous articles, textbook chapters, and one of the cover editors of 6 textbooks. So really, it's our great pleasure to bring you Dr. Leo Scorin, and I know I'm going to be looking forward to this because this is a topic of interest of mine. So with that, Leo, thanks for doing this, and please take on over.
Thank you very much. And that was a very nice introduction. And good evening to everybody. I assume it's evening for most people that are listening to this right now. I am a neuro-ophthalmologist in that I did do a neuro-ophthalmology fellowship. I also practice as a general ophthalmologist and do cataract surgeries and everything else. And one of the other things I'd like to point out as we move on to the next slide is I have no financial disclosures and no conflicts of any kind. So basically, when I did my fellowship back in the 1980s, there was an old aphorism that said that neuro-ophthalmology is a field with 1,000 diagnoses, but only one treatment. And that treatment was steroids. And we use steroids orally, we use steroids intravenously, high doses all the time, because we really didn't have much of anything else. And that is simply not true. That aphorism is simply not the case anymore. It's no longer true. Currently, there are a myriad of treatments, injections, intravenous infusions, other capsules, tablets, etc., that now exist that did not exist when I was doing my neuro-ophthalmology fellowship. And all of these are out there to suppress the immune system's attack on the nervous system. And so we're going to move on and start with one of the particular neuro-ophthalmic diseases out there that is very common, and we see this, optometrists see it, ophthalmologists see it, family medicine doctors see it, neurologists see it, emergency room doctors see it, and the thing is, can we make the correct diagnosis? And basically, that we're going to be talking about temporal arteritis. And that starts off in the eye as anterior ischemic optic neuropathy. And anterior ischemic optic neuropathy is basically mostly found in people over 50 years of age or so. And it is due to ischemia to the anterior part of the optic nerve head. And there's involvement of the posterior ciliary artery circulation. And this is an end artery system. And that's why basically when I explain to a patient, oh, you've had this issue, I explain it to them as a stroke in the eye, and they seem to understand that better. It needs to be considered, in any differential diagnosis if you're talking about sudden vision loss, and visual field loss is always present in these patients also. And so we need to distinguish between the two types, arteritic versus non-arteritic, and the arteritic is the one we're going to be talking about because that's the inflammatory factor. It's due to inflammation, basically, and traditionally always treated with steroids. While the non-arteritic, which is actually the more common type, and basically that is some underlying ischemic disease, vasculopathic ischemopathic type of disease like hypertension, hypercholesterolemia, diabetes, sleep apnea, a whole bunch of other things like that that could be the cause. And for non-arteritic, we really don't have a known treatment for that, except to address the underlying disease process itself. So now let's just talk about arteritic, also known as giant cell arteritis or temporal arteritis. And it presents with both ocular manifestations and systemic manifestations. The ocular ones are, as we were talking about, is this arteritic ischemic optic neuropathy. And if you see the image there on your upper right, that's of an optic nerve head that's got pallid swelling. So it's sort of ischemic-like swelling. And that is very typical presentation for someone with giant cell arteritis. But a lot of times people forget that diplopia, and it could be any type of diplopia, horizontal, vertical, torsional, that patients can present with if they are over 50, 55 years of age, new onset diplopia, that may be one of the first signs of potential temporal arteritis and ischemic optic neuropathy. Basically, you have about 2 weeks from the onset of the diplopia until a patient may start developing this ischemic optic neuropathy event to the disc. And we all know that's really a pretty devastating visual event. But also included in there is retinal artery occlusion and even amaurosis fugax. Sure, whenever a person presents with that, we should consider the carotid artery if you see any hole-in-horse plaques, or if you see calcific plaques, you might want to consider that being a cardiac etiology of some sort. But these events can also be the first signs and symptoms of this temporal arteritis or giant cell arteritis. Think of it as a transient ischemic attack in the eye. And nowadays, we have to, if somebody presents with a retinal artery occlusion or amaurosis fugax, hole-in-horse plaques, those patients should be sent to an emergency room where they could have a stroke workup done. So it's considered emergent enough that it should be not sat on, but sent in for that evaluation. At the same time, most of those stroke centers will also work these people up for temporal arteritis. If not, you should be in contact with them and say, look, we need to get these particular tests. We'll be talking about them shortly to see if there's a potential that this may be the presenting sign or symptoms for temporal arteritis. Now, systemic manifestations, and by the way, the middle photo there shows the classic cherry red spot that we'd see with a retinal artery occlusion. So systemic manifestations, usually people present with a headache. It's usually a temporal headache, so in the temple area. The second most common place that people will have pain is actually the occipital area. So they may have temporal headaches or occipital headaches, and those are typical if they're presenting and if they're an older individual, and this is a new onset headache that they've never had before. The other classic presentation is what's called jaw claudication. And that's actually ischemia to the masseter muscle. So the person who's chewing, using that muscle, they get ischemia from use. These people may be losing weight and they're not trying to lose weight. They may have, in addition to headache, they may have what's called scalp tenderness, so that if they try to put on a hat or if they comb their hair, it's just like their hair hurts. And so that's another presentation. Myalgias, arthralgias. Patients often who have temporal arteritis will also have a history of having polymyalgia rheumatica, possibly months to years before they actually present with temporal arteritis. Some neuro-ophthalmologists even consider polymyalgia rheumatica as the form thrust of temporal arteritis. So it sort of grows up and becomes this more dangerous temporal arteritis where people lose vision. By the way, polymyalgia rheumatica is also treated with steroids, but usually low-dose steroids, and that controls them pretty well. They may have fever on presentation, like fever of unknown origin type of thing, usually low grade. They can have fatigue, ennui, all these other things. And on the lower inferior right photo there, one of my patients is sticking their tongue out at us. This is a gentleman who came in with a lot of this symptomatology, and he goes and he basically tells me, by the way, I have these lesions on my tongue too. And when I took a look at them, I could see that this is basically lingual claudication or tongue claudication. It's the lingual artery that's being affected. It's sort of in the same vein as jaw claudication. Not seen that often, but it was interesting enough, and I took a photograph to share with you.
Hey, Leo, I always like to point out to the audience when you see that cherry red spot, that's like the largest cotton wool spot that you'll ever see, because the whole nerve fiber layer is kind of swollen there. So we usually see cotton wool spots that are very isolated. When we see that, the whole kind of nerve fiber layer, so it's like one of the largest cotton wool spots you ever see. So just a little comment I always like pointing out. So
yeah, I never thought of it that way, but I think you're right on the money. That certainly is a good analogy. Thank you. So what are the tests to diagnose temporal arteritis? Well, the first test you should do is basically order some blood tests on these patients if you suspect that they may have this. You order a Westergren erythrocyte sedimentation rate. There are maybe still some Wintrove tests out there, but it should be a Westergren. You want a C-reactive protein. You want a complete blood count, and you're looking for normochromic, normocytic anemia. And of course, usually in most CBCs, you'll get platelets, but just in case with the lab you're dealing with, make sure that they also include platelets. And depending on which tests are positive, your odds of having eventually a positive temporal artery biopsy can increase. For instance, if your SED rate's between 47 and 107, then it's 1.5 times greater chance that that person will have a positive temporal artery biopsy. The one that's even more critical is a C-reactive protein. If that is elevated, then it's over 5 times greater chance that the person will have a positive temporal artery biopsy. And even the platelets, if they're over 400,000 microliters, and 400,000 for most labs is the top level of what's considered normal for platelets, it's 4.2 times greater chance that the person is positive for temporal arteritis. And of course, if multiple tests are positive coming back of these tests, then it increases the chance that the person truly has that disease. But really, the only definitive way is a temporal artery biopsy. So you're using the tests, the blood tests, to basically make the decision, the clinical decision, to proceed with a temporal artery biopsy. So you're taking the systemic presentation and the ocular presentation, the signs and symptoms, you're adding the tests to make the decision whether you're moving on to a temporal artery biopsy. For me, it's more or less a no-brainer to go ahead and do the temporal artery biopsy. I do these myself. I learned them during my fellowship. They're pretty straightforward, but if you don't have a neuro-ophthalmologist available, check to see if you have an ophthalmologist. Not all ophthalmologists do this test, So then you might need to see a general surgeon, possibly even a dermatologist, oral maxillofacial surgeon. So there's a number of different vascular surgeons, a number of different individuals that may be able to help you and do a temporal artery biopsy for you. So on the lower left-hand image, that's one of my patients, and you can see I've isolated out the artery itself. And that's what I remove to send into pathology. The pathologist does histopathologic evaluation, and that's what you see on the right-hand side. And basically, the arrow is pointing to a classic giant cell. These multinucleated giant cells, that's where we get the name of the disease, is giant cell arteritis. So the traditional treatment has also always been corticosteroids, and the initial traditional treatment still is corticosteroids. The debate is whether it's intravenous versus oral. In my mind, if there's any ophthalmic presentation, then I always first start off intravenous and then start to taper with oral, because you want to get that under control. If they don't have any presentation really ocular, other than headache and maybe some of these other things, then I may just start them off with oral as long as there's no ophthalmic presentation. And so I'm going to go ahead and show you just a quick temporal artery biopsy. So first, I isolate where the vessel is. I numb it up with lidocaine. Then I test, and then I use a number 15 Bard Parker blade to make an incision through skin and subcuticular tissue. You don't want to go too deep because you'll cut into the vessel, obviously. The vessel sits on top of or within the temporalis musculature, which is what I'm basically dissecting through. Once you isolate the vessel, I just clip them off with these little titanium clips proximally and distal, and then you got the vessel segment in the center that you're going to excise. So then I excise that specimen. I try to get at least 1.5 to 2 centimeters in length. 2.5 is ideal. Sometimes you can't get that long, but essentially that's the specimen that gets sent off to the pathologist, who then sections it. I do subcuticular closure with dissolvable sutures, then Dermabond glue, and steri strips. The steri strips fall off in about a week to 10 days, and then the incisions basically heal nicely at that point.
Excuse me, Leo. Do you do bilateral or just unilateral?
I will address the area in question. So let's say the headache is more on the right side, or the patient has had ischemic optic neuropathy event on the right side. I will just do the right side. I used to do bilaterals, and then I realized that I wasn't giving the patient a spare surgery down the road in case they needed a second surgery, because this disease has a tendency to recur. And so then if I do both at one time, yes, that increases your yield potentially, but then you basically you've eliminated any surgical intervention in the future if you want to verify a recurrence of the disease, unless you do an occipital artery biopsy, which I've never had to do, thank goodness, because I'm not sure exactly where to even look for that one. But,
yeah, that might I would think that might affect vision somewhat if you did that.
The occipital one?
Yeah.
Yeah.
Oh,
No,
I'm sorry. I thought you said ophthalmic.
no, I said
I have one more
occipital.
question.
No, it's
Yeah,
occipital.
okay. I got a quick question. If you're going to cover this later, we can table it. But what is your thought on temporal artery ultrasound? See, in my practice, none of our ophthalmologists will do a biopsy, but we have a vascular surgeon in the Sarasota area that will get me a same day or next day temporal artery ultrasound.
Right, and that's the issue. There's actually a study at Mayo going on right now at looking at the efficacy of these ultrasounds and what are the criteria. How do you know if it's positive or negative, etc. The biggest drawback is that it's usually a technician, ultrasound technician, that does these tests. It's not the doctor who's doing them, and you have to have someone who's highly skilled and does a lot of them. These ultrasounds, to be able to actually give you more than garbage in, garbage out from the testing. So right now, the weak point is basically, do you have a skilled technician, ultrasound technician, who's done a lot of these, knows how to do this, and can get you that information? And in areas like where I'm practicing right now, we just don't have the people that have the skill set to be able to give me the information that I need. So right now, the biggest problem is they haven't yet found out exactly what the criteria is. That's what they're doing studies on that. And that may be in the future that may have basically take over for the biopsy itself. Okay.
Thanks, Leo.
So, no problem. So we're going to move on. So this is not a real new medication, but we now have basically a medication, monoclonal antibody medication, that is specific It's the first FDA-approved drug to treat giant cell arteritis. We've always used steroids, but they've never been FDA-approved. But this drug is. Now, it's not a new drug. It was around since 2010, and it's been used for treatment of rheumatoid arthritis and juvenile rheumatoid arthritis. It's a humanized monoclonal antibody, and I'll explain what all that means. But basically, it binds to interleukin-6 receptors, which are pro-inflammatory cytokines, and basically quells the inflammation. You always start with steroids first. Even before you do the biopsy, you want to start with steroids first. If they have a gangbuster presentation, if the blood tests are coming positive, start them on the steroids, and then get a biopsy. You could get a week or 2 weeks later, you can get the biopsy and you'll still have positive results if they have the disease. And the same thing if you're going to use this tocilizumab or Actemra, you want to start with steroids, and then you want to add the tocilizumab. I like this drug because it's subcutaneous, so patients can go home and use it themselves. They could give these injections sub-Q themselves. And then you do the quicker taper, like 26 weeks taper, which is like 6 months or so taper. And it's been shown that at 52 weeks, 56% of patients achieve a sustained remission. I'll tell you, the biggest problem with treating just with steroids temporal arteritis is as the numbers of the blood tests go down, as the symptoms go away, you start to wean off the drug, and then everything starts to flare up again. Basically, a remission starts happening again. Or not sustained, non-remission. It's the disease starts coming back again. And then you're playing with the numbers, you're increasing the dose, you're decreasing the dose. And you're doing this it's not a few months, it's years. It could take several years before you basically quell the disease itself. And so this new monoclonal antibody basically minimizes the exposure of steroids, which, by the way, are not benign drugs, for the patient to have to use for very long term, and basically eliminates the disease or minimizes the disease to the point that it's non-existent, essentially, and the patients can get off of both of these medications down the road. So it's really a great drug. Unfortunately, all of these monoclonal antibodies increase the risk of infection for patients. They can also cause thrombocytopenia, this drug in particular, which is a low platelet count. They can affect the liver function enzymes, increase the cholesterol and triglycerides of the patient. And so you have to monitor all of these tests on this patient. That's why I don't like personally prescribing this medication. I'll always start with the steroids aspect, but I quickly start to co-manage this with a rheumatologist. Rheumatologists are basically internal medicine doctors who subspecialize in rheumatology, and I let them deal with all of these potential problems and the monitoring of the patients. So they sort of prescribe the Actemra, and they keep on monitoring them to see how they're doing and not having any of these potential side effects, which as an ophthalmologist, I don't personally want to deal with. So we have the first poll question.
With that said, I'll get it opened up right now. It's opened up. And the first question is, the 4 laboratory tests which should be ordered when diagnosing giant cell arteritis, temporal arteritis are, and there's a whole list there. I'm not going to read it. There's A, there's B, there's C, and D. And the answers are rolling in. I'm going to go check the polling questions. Or not the polling questions, but the questions. It looks like we're caught up here. Nothing is rolled in. Let's see what's happening in the poll. All right, looks like you did a good job here, Leo, because 94%, I'll display it, 92% have said ESR, C-reactive protein, complete blood count, and the platelets. So C-reactive protein should go up, CRP should go up. In the CBC, is it my understanding we're looking at hemoglobin, that one goes down and then platelets go up? Is that the key?
Yes, they usually patients will present with normochromic normocytic anemia. That's correct.
So there we go. All right.
Great.
So I'll close the
I-
polling question and go ahead and pick up when you want.
Okay, I am glad that they did so great. Thank you all. That means everybody's paying attention. Good. I'll try to keep paying attention. All right. So we had talked about this drug, and I sort of said to you, what is that drug? Well, it's one of the list of biologics that are out there, these new drugs, and they're sort of just coming out left and right, not just for neuro-ophthalmology, but for other diseases too. But what you always want to look at the suffix, the ending, and the ending sort of gives you the idea of what drug you're dealing with. So tocilizumab, MAB, if you see anything that ends in MAB, that's a monoclonal antibody. If you see something that ends in NIB, NIB, that's tyrosine kinase inhibitors. Septs are synthetic receptors, and MODs are fragments of antibody immune modulators. What we're going to cover with all these neuro-ophthalmic diseases are mostly MABs, and then there's one new MOD out there for myasthenia gravis of all things. So we'll cover that here in a minute. So let's look at monoclonal antibodies. What the heck are these? Well, these are basically, they're all the same. So monoclonal means mono, they're all from one, basically cloned from a single B lymphocyte, for a very specific target. So all of these monoclonal antibodies are for very specific targets for these particular neuro-ophthalmic diseases. So there are different parts of this particular monoclonal antibody. So the first part is called F, which stands for fragment, antibody binding region, so FAB. And if you look at the diagram on your right, that's where number 1 is. So that's where the arms are sort of sticking up out to the right and to the left. Then you have the second tail part of it. That's what it's called, a tail. It's sort of this FC, which is the constant region. It's sort of the crystallized region. That's the tail of it. And then the the antigen binding sites, that's the variable region. And that is the very tips of the FAB, of number 1, essentially, the antibody binding region. So number 3 are the tips of where the antigen actually binds to the site. So that's basically a monoclonal antibody and what it looks like, the constant and the variable site. So how do you get it in the first place? Well, first you have to immunize some sort of subject that could form these immune response. And the one that was always worked on was mice, the murine, although we use humans too. And then you take this tissue culture, they call it a tumor, but it's not like a tumor that you and I would think of like a cancerous tumor. They consider it, sort of some sort of tissue growth that they use. It doesn't have to be like a cancerous tumor. And then they combine it with these antibody forming cells from this immunized animal or human that you've used. And then you get these things that are called hybridomas. And then these hybridomas are screened for specific antibody production. So they find the one that is producing the antibodies that you're looking for, basically. And so those are the ones that are cloned. And that's how you get the monoclonal antibodies, essentially. So they take the one that is functioning the way they want it, and then basically they clone more of them. And then they basically cleave off the monoclonal antibodies. And these can be then isolated for cultivation. That's as necessary. So that's the process of it, a simplified process. So how do you get these different names? Basically, so if you see our FAB and FC components, remember FC is always constant. So FAB is the one that sort of changes, especially the tips, the very ends, and you can see the different colors there at the very ends. So if you're dealing with a human, subject, that's UMAB. So that's where you obtain it from humans. If it's murine, so it's 100% from a mouse, it's MOMAB. And most of these are chimeric or humanized. So chimeric is a ZOMAB, where like 33% murine proteins are used, or humanized, where you have ZUMAB, with only 10% are murine proteins that are utilized to get these monoclonal antibodies. So let's look at some terminology here. So the prefix of the drug name is just whatever the company wants to call it, to come up with. Then the infix is the target infix, basically is what you're looking to work on, essentially. So if you look down 1, 2, 3, 4 to where it says immune in the very center where it says target infix, you see it's LI or LIM. So that's what we're going to see the most of. Although we're also going to see one that shows TUM, which is a miscellaneous, they say miscellaneous tumor, but it doesn't, again, it don't mean necessarily a cancer or something. That's just miscellaneous name that they're going to use. Then there's a source infix. Where is it coming from? So if it's strictly the letter U, it was drawn from humans. If it's an O, it's from mice. But most are either XI or ZU, ZU meaning humanized. So that's like only 10% murine. And then the suffix, as we had talked about in the very beginning, that tells you if it's a MAB, you know it's a monoclonal antibody. So if you look at the bottom, some examples, this adalimumab. So the ADA is the prefix. That's just the company name. LIM, if you look up the chart, LIM means it's the immune system it's working on. U, so it came from human, and MAB, it's a monoclonal antibody. The next one is efilizumab, EFA, company's name. And here they, instead of using LIM, they just use the LI, still means immune. ZU, which humanized, so it's not pure human, there's still 10% murine or mouse in there, and then MAB. And those are not drugs that we're that familiar with, but here are some that are. So we've already talked about Actemra or tocilizumab, and if we break it down, the TOSA is just the company name, LI, right? Anti-inflammatory, ZU humanized, MAB monoclonal antibody. How about bevacizumab? Ever hear of that? Well, that's Avastin, right? I use Avastin all the time when I do intravitreal anti-VEGF injections. So the Beva is the company name. The CI means cardiovascular. And in our case, it's not the cardio part, it's the vascular aspect against neovascularization. That's what we're using this drug for. It's a ZU, so it's humanized, and it's a MAB. And how about teprotumumab? So teprotumumab is a new drug. It's relatively new. Most of you have probably heard of it. It's Tepezza, used for thyroid disease. So Tepro is the company name. Tum, and remember, this means tumor, but this, in this case, it's the miscellaneous because it's not really against any particular tissue except the broad inflammation that you would find in the orbit. U, it's human, so it's not, has no murine in it, and it's a MAB. So let's talk about thyroid eye disease, which is our next neuro-ophthalmic disease. It's the most common autoimmune disorder of the orbit. It's 5 times more common in women, but if it happens in men, usually it's more severe in men. There's 2 phases. The active phase is the inflammation phase. That's where the patient comes in with the onset of proptosis, pain, diplopia, redness, edema, and then eventually that quiets down into the inactive or fibrotic phase, and that's where the patient has their restrictive myopathy. The signs and symptoms, the most common one is eyelid retraction, which is like 92%. And in about the 50% range, you get proptosis, diplopia, extraocular muscle dysfunction. Then there's lesser ocular pain, dry eyes. And the most serious one, and thankfully it's also the least common, is compressive optic neuropathy, which causes vision loss. So traditionally, if it's been a mild type of presentation, a lot of times we'll just monitor them because some of these people do have some spontaneous improvement. If it's moderate to severe, usually we've been doing 12 weekly infusions of high-dose intravenous methylprednisolone, or IV methylprednisolone. And of course, if it's sight-threatening, then they need orbital decompression. But steroids, are not suitable for like long-term use. We're all familiar with that. They really don't target the pathologic mechanisms. They don't reverse the proptosis and the strabismus, which is, basically it's a lot of times we'll send patients to oculoplastics to fix that. So they need some sort of surgery. And of course, they have substantial side effects. And really, the treatment has been changed for how we approach this disease, because now we have this Tepezza or teprotumumab, and it's the first FDA-approved drug for the treatment of not only acute, the inflammatory, but also the fibrotic or the chronic thyroid eye disease, which is very unique for a drug like this. Remember, it's a human monoclonal antibody. It's the U only component, so we know it just from humans. And it actually addresses the insulin-like growth factor 1 receptor inhibitor. So it blocks the autoantibody attacks on the orbital cells themselves. So it's very point specific. This is a drug that could be prescribed by ophthalmologists, but mostly is prescribed by endocrinologists and oculoplastics doctors out there. But ophthalmology is working with it too. It's an infusion medication. You need a total of 8 infusions. So I don't do these in my office. We have an infusion center in the hospital, so we just send it there with the orders, and the nurses do that. But it's interesting, this disease actually decreases the proptosis and also improves diplopia, which steroids really don't do well. It reduces the orbital pain, the redness and the swelling, and basically makes the patient look normal and possibly avoid surgery, oculoplastic surgery. So at 24 weeks, which is about 6 months, or it is 6 months, basically those 8 infusions have been administered. And the studies show that it reduces proptosis an average of 3.3 millimeters in up to 83% of patients, which is like a lot. And also the response is maintained up to 72 weeks, from baseline and up to a little bit more than half of these patients. It also decreases signs and symptoms of inflammation, as we had talked about, in almost 60% of patients after their 8 infusions that they're supposed to receive. So you can see the images on the left is the patient pre-infusion, and on the right after infusion of all 8 infusions, how the scleral show is decreased, the eyelid retraction is much better, especially in the left eye. It's a little bit left on the right eye, and the inferior images basically show the proptosis has receded significantly in these individuals. There also affects, of course, the diplopia that can occur, and that's up to 53% after 6 months or 8 infusions, and it's durable response for up to 72 weeks. So it's maintained for a long period of time. On the lower right image, you could see that's an MRI scan showing the extraocular muscles, and you can see, especially the inferior oblique, how it's lighting up. And you can see debris within the orbital, inflammatory debris, you see it lighting up. And then the image on the right, you can see that this is the exact same patient after 24 weeks. You can see the extraocular muscles essentially have retained, and now they're normal size. They're no longer lighting up. So that means the inflammation is quelled. And if you look inside the orbit itself, you don't see all that white flocculent type of inflammatory debris that we could see in the previous image. Here's just some examples of some patients after their 8 infusions. The one on top on the left, you can see the right eye is proptotic, and it's back to where it should be with the image on the right, upper right. The lower left, you can see this patient not only has proptosis, but also if you look at the reflex, pupil reflex, you could see that the right eye has basically an infratropia. After 6 months, 8 infusions, 24 weeks, you could see in the inferior right image, you could see the proptosis is significantly improved. The patient still has a little scleral show, a little more noticeable on the right and the left, but it appears that the reflex, pupil reflex, is equal in both eyes with minimal displacement. So if this person did have diplopia, which I assume they did on the image on the lower left, it's probably resolved or minimized to the point that it's inconsequential on the image on the lower right. So this drug, like all the other drugs, has unique adverse effects. Infusion reactions are something we could take care of at the infusion center. That's usually not that much of a problem. But muscle spasms are an issue. Hyperglycemia, so you could induce diabetic-like changes in these patients. You have to be cautious if they have a history of any type of inflammatory bowel disease like Crohn's disease, because that could be exacerbated. It has all these other funky things, but the main one, and this is something you have to really pay attention to, is hearing loss. So if a patient has pre-existing hearing loss, they are at a much, much higher risk after receiving these infusions of getting more severe permanent hearing loss also. It's to the point that basically all these patients now have an auditory examination, to even the ones that don't have any history of hearing loss, just to get a baseline, so as we can see if they are actually losing any hearing or not, because that is usually permanent hearing loss. And there's been a number of litigious factors coming in with this, because this was not something that was picked up on initially when the drug came out, and now we're seeing that it is a major risk factor. But otherwise, there are really no contraindications to using this drug, which is also a unique factor of this drug. Okay, we're going to do poll question number 2.
So polling question number 2 has already been opened, Leo. It is recommended that each patient who is starting teprotumumab for thyroid eye disease have the following tests. So Leo, I do a lecture on thyroid and thyroid eye disease. So the question I'd have, since we have a nice size audience of optometrists here tonight, when are you making that kind of referral for that infusion? I know the clinical activity score, like we had the no specs and the LEMO classification, which kind of tells us what's happening. The clinical activity score was used during the studies, and it talks about the plica being red and pain and chemosis and so on and so forth. When do you, because sometimes we just see like kind of like a bad dry eye with these patients. Are you waiting for the proptosis? When are you making that referral for the infusion?
I am usually what I do is if a patient has proptosis, diplopia, a lot of times, like you would point out, ocular pain. Now, you may be able to address that if it's just dry eye with more intense dry eye therapy. If that works, that's fine. But if I'm seeing any of that, then that is, then that's the acute phase, and I'm definitely, considering them high, as a potential patient to start the Tepezza. And I also get a auditory examination. We have an audiologist on staff, and not on the ophthalmology staff, but at the hospital we have an ENT department audiologist, so it's easy for me to set them up for an audiologic evaluation also. So I don't start it until I get the audiologic evaluation, basically.
Right. Great. Well, you're going to like the audience, and I'll display the response here. We have 86% saying get that auditory evaluation for the patient before doing the teprotumumab. So
right, I agree that is the way to go, especially now that you see TV ads for lawyers saying, "Did you lose your hearing on this drug? Contact us." So when I saw that, I said, "Oh, everybody's going to switch quick here," and they have. All right.
Yeah, and the key is too is that what was they were using Humira and Remicade for these patients before teprotumumab came out, and those are big boy biologics that are suppressive. This is more kind of immunomodulatory. So comparing it to the other biologics that are out there, this is certainly a much safer medication. So I would encourage most of the optometrists listening to learn this medication, figure out when they feel comfortable referring it, because it is, compared to the other biologics, definitely safer.
Right, you're 100% right. And if you look at how we did 12 sessions of infusions of steroids on these patients, you know, I mean, if the patient was a little crazy, they really came out super crazy at the end.
Yeah.
So, I mean, steroids were not a benign drug either. So, really what we had before, what, like you had pointed out, it was not, like, latanoprost versus pilocarpine or something, we were using pilocarpine. Now we could use latanoprost essentially. If that, I don't know how good of an analogy.
No, that was a good analogy. I like it.
But I'm
For,
going to
for those that are old enough to remember pilocarpine, though, that's the key.
Oh, that's the problem. There's too many youngsters out there and they don't know what that is potentially. Well, anyway, let's move on to the next disease. Now, this is one that most of you probably have not encountered. I hope you haven't encountered them, because then you have a really sick patient out there. But this is neuromyelitis optica spectrum disorder. It's known as Devick's disease. I think the name is dropped off essentially, but it was named after Eugene Devick back in the late 1800s. He wrote the first papers on him. And so that's his picture down on the lower left. He's not a relative or anything. I just happened to come across it, so I thought I'd throw it in. My first experience ever with this drug, with this disease, was actually during my fellowship. I was a young guy, and here they're rolling in for our examination at the University of Illinois. They're rolling in this young man in his early 30s. He's blind in both eyes, and he's in a wheelchair. And it like happened overnight. I can't say it happened overnight, but very quickly he deteriorated. And it just floored me, because, he was a bit older than I was and all that. But basically, I looked at him and I said, oh my goodness, what the heck is this? And even then, we suspected what it was. And this was in the 80s. So MRI was just starting to come out. I don't even know if I think we may have had a rudimentary MRI at the university at that time, but we didn't have the technology to actually even work up this patient other than clinically to see if this person has this Devick's disease. And Devick's disease is very specific. You have to have this bilateral simultaneous optic neuritis, which leads to optic neuropathy, that involves the long segments of the optic nerves. So that upper right image, if I move this little arrow, do you guys see that there?
Yeah, yes, we do.
Oh, thank God. Okay, good. All right, so you could see the long segments of the optic nerve lighting up here, and that basically is one of the clinical imaging findings that you have to have. And the other one is they have this transverse myelitis, so it affects the spinal column basically, that involves at least 3 vertebral segments. So you could see the inflammation running from this arrow to this arrow. You could see it lighting up there. So that's 1, 2, 3, 4, 5, 6, possibly. And here it's like 3 segments, 1, 2, 3. So this person, if they had these 2 clinical images, and when we scan them, then they would qualify by neuro imaging as having Devick's disease. And before that, we had nothing but just clinical evaluation. And of course, we would bang these people with IV steroids. So the median age of these patients is around 40 years. It could be more active during and immediately after pregnancy. We have also recently discovered that there's this area postrema, and we call it area postrema syndrome. These patients may initially start presenting with this protracted nausea, vomiting, hiccups, fatigue, severe pain. And I'm going to show you some imaging of what we're now trying to image to see if it lights up. And if it lights up, that's the area postrema syndrome. And that's a classic sign of this disease beyond the bilateral optic neuritis and the spinal column testing that we do. So these patients eventually develop this ischemic optic neuropathy. They can have, which causes bilateral blindness. They have spinal cord ischemia, which leads to paralysis. They could get this neurogenic respiratory failure, which leads to death. Doesn't sound like a real fun disease here. And they have this relapsing course. And every time it relapses, it gets worse and worse and worse. So there's no like recovery. It just sort of compoundly gets worse. And the prognosis has always been poor with this disease. So within 5 years, 50% of these patients are blind in one or both eyes. And usually they're in a wheelchair. So so you can see it comes on rather quickly. Well, guess what? We now have a blood test for this disease. Beyond, you still do all the neuroimaging, but now we also have a blood test for this disease. Basically, it would be for this, it is aquaporin 4 IgG, and it looks for these positive autoantibodies against the aquaporin 4 IgG. It's 80% sensitive and 90% specific. It's a great test. Actually, it was developed here at the Mayo Clinic. So there are two types. There's a cell-based and there's ELISA. And you should order the cell-based assay testing. That's the more accurate one, has a higher sensitivity and more specificity than the ELISA. But still, up to 30% of these patients will be seronegative, even though the symptomatology and the neuroimaging tell you basically they have the disease. So it's not 100%, but it's definitely a test that needs to be ordered. So now we think this may be in the spectrum of multiple sclerosis, because we also have this other disease called MOGAD, which is myelin oligodendrocyte glycoprotein antibody disease that patients present with that sort of mimics this disease, but they're negative for the blood test, but they're positive for the MOG, immunoglobulin G antibody test. And this is actually more common in children and young adults. Both sexes are affected equally. They get optic neuritis, myelitis, but they also get this brainstem demyelination and this acute disseminated encephalomyelitis. And when you do the tests on these patients, they're negative for the aquaporin 4, but they're positive for, like I said, this MOG IgG antibody. So nowadays, if you have someone who presents with potential optic neuritis, multiple sclerosis-like presentation, we're basically ordering both of these blood tests on these patients also, because they may potentially progress, become one of these, evolve into one of these other type of diseases. So we want to catch those if we can, because when we address them, potentially a little bit different. So nowadays, I think the standard is basically if you suspect MS on a patient that has no history of it before, so it's a new diagnosis, we usually throw in these other blood tests too, just to make sure we got all bases covered. Basically here, what we have is some imaging. And the main thing I wanted to show is the far image to the right. And this is that area postrema that we're talking about. Basically, it's adjacent to the fourth ventricle. And you could see right here where the arrow is pointing, you could see it's lighting up right there. So if you have this within the clinical presentation, besides just the bilateral optic neuritis and the spinal column being positive, you have the area postrema, then you're basically almost, from the neuroimaging alone, you're probably sure that they have the disease, but you still get the blood tests and all that also just to verify it. So it's acute treatment for these disease. Remember, this disease hits quick, hits hard, and causes a lot of damage from the get-go. So you want to hit it in reverse. And we always go with IV methylprednisolone for 5 days on these patients. And then we start to taper with oral prednisone. And then if they're not showing recovery, then basically we do 5 days of plasma exchange also. If the person comes in, they're bilaterally blind, they're in a wheelchair, all the other neuroimaging is positive, and they're really doing bad, we will oftentimes start both the IV methylprednisolone and the plasma exchange simultaneously on these patients. And so that's also acceptable. So you could do it staggered, or you can do it together. Now you're going to say, why don't we just go ahead and the blood test will tell us for sure, right? The problem is it may take a week or more sometimes to get the blood tests back. So you can't have the patient just sitting around doing nothing for 7 to 10 days. So that's why we have this other regimen set up for the acute treatment. The chronic treatment, and that's where we start getting into these biologics, which we didn't have before, helps long-term function. So these B cells are stimulated, they produce these antibodies to the aquaporin 4, causing this periarterial inflammation. We now have 3 different medications that are FDA approved to use for this disease. And they can only be initiated if your blood test for aquaporin 4 comes back positive for those antibodies. So that's why you have to do the test also. And
Hey, Leo, can you explain real quickly what a plasma exchange is?
Basically, they take out your cells, they take out your blood, and then they filter it, and they give it back to you essentially.
So they're using the person's plasma. They're not using someone
Yeah,
else's plasma like you see.
To filter out the inflammatory factors that are in there essentially.
Perfect. Thank you.
Do you do that at Mayo, and who's the specialist that actually runs that?
Not me. Usually I will send it to the neuro-ophthalmologists that are actually, I'm in Albert Lee, which is about an hour away from Rochester. So Rochester would do that. We don't have the capabilities. We do infusions at our hospital, but we don't do like plasma exchange or anything like that. Those patients would be sent to the main neuro-ophthalmology department within ophthalmology in Rochester.
Perfect. Thank you.
Dr. Chen is one of the neuro-ophthalmologists there, if that's what you're asking. So basically, there's 3 different drugs. There's satralizumab. Now, MAB, you know, it's a monoclonal antibody. It's also known as Enspryng. And basically, this drug and inebilizumab, another monoclonal antibody, if you look at the relapse-free rates for these patients, they're very good. They're in the 70 to 80 percentile, essentially. So they're relapse-free, so they don't get those second and third attacks when you start implementing these drugs. But the drug that's used more commonly for this disease on a chronic basis, for the chronic aspect of it, is this eculizumab or Soliris. There's even a biosimilar for it now. And it's an anti-C5 monoclonal antibody. It binds to the complement component. That's what's the inflammatory cascade component, essentially, and it inhibits the complement. So it prevents inflammation, cell destruction. It's intravenous. And the reason this has sort of become the favorite drug is because its relapse-free rate is like 96%. So the others are great too, but this one has like an unbelievably high relapse-free rate. And all of these drugs give you infections. So you have to, these patients really do have to be monitored closely. Okay, polling question number 3.
All right, it is open. So those that are not seeing it, I'm not displaying the answer yet. If you go to the polls, those have made a couple comments. It's open now. I can see that it's open. You're not going to see it pop up until I display it with some of the answers. But the question is, acute treatment for neuromyelitis optica spectrum disorder may include the following 2 therapies. And I'll have you go through A, B, C, and D there. Intravenous methylprednisolone and plasma exchange, oral steroids, and my pointer's in the way, oral steroids and generalized radiation, intravitreal saline and lymphatic exchange, focal radiation plaque, and topical steroid drops. People are responding, so I know that it's open. Joe, go ahead, please.
Leo, in my academic career, one thing I had noted was if anybody got confused or didn't recognize something in the retina, it automatically defaulted to some sort of white dot syndrome. What I'm seeing in neurology, and some other specialties is if they don't understand, they don't have a diagnosis, it seems to always now default to NMOSD or MOGAD. And I've had patients come to me and tell me that my doctor's looking, to get these antibodies, and you said it's bad disease, and these are people who are Googling this, and they're seeing a really bad prognosis. And sometimes I just have to say, look, your doctor is just getting desperate. You don't have these diseases. There's nothing about your clinical findings that tell me this, that you have this. A transient ischemic attack is not NMOSD. So unfortunately, it seems like these are the defaults. People, if they can't find a diagnosis, they're going to start testing for these diseases, even though they're not clinically appropriate. So I hate seeing that.
Well, I agree with you. I mean, basically, we've all been taught this. You need to treat the patient, not the test, basically, and chasing tests around is not a good idea. But I think some of it is because Mayo Clinic is a tertiary center. Essentially, it's very typical to sort of do all the testing and look for everything, because we don't want to miss this odd thing here in the corner just because we didn't do that one blood test on them. But if the clinical presentation is nothing like MS related issues, then why would you even think of any of these tests to run on the patient?
At least what I'm seeing is it's new. People don't understand it, and they're like philosophers searching for truth. If they test long enough, they'll get the answer, and that just is that. I've had talks with people, pretty young, healthy people off ledges, thinking that they're going to be disabled within a couple of years.
Yeah, you might. You know what? In some respects, you're quite right about that. That I think it is new, and you're right. I don't think we understand it completely. But in the same vein, you don't want to miss it, because there are valid interventions for it if they do have it. You know what I'm saying? Because now we have drug. Before it was like, we think you have this. It doesn't matter. We're going to treat you with steroids. But now we could sort of dovetail particular, and even for multiple sclerosis, even if it turns out to be run-of-the-mill MS, if there is such a thing, there are a lot of different drugs out there to treat patients for that, to minimize the damage that they may incur if they're not treated appropriately. So I think so it's a two-edged sword.
But one case I can think of was a 50-year-old man, healthy, who had 2 bouts of transient vision loss, one in each eye in different times. Had been worked up stroke unit twice at the ER, found nothing. Already had bilateral temporal artery biopsies, age 50. That was negative. And he said, now they're looking at MOGAD and NMOSD. And I said, dude, stop Googling it. You don't have those diseases. You're going to be fine.
Yeah, I don't know what to tell you. I mean, we do have patients that we order a lot of stuff on, and then at the end we still sort of say, I don't know what you have.
Oh yeah. It's like I said, don't be a philosopher searching for truth.
You're doing well. They're paying attention here. The polling question, I've displayed it. It says the acute treatment for neuromyelitis optica spectrum disorder may include the 2 following, and 95% got intravenous methylprednisolone and plasma exchange. So
excellent. Good job out there, everybody. All right, let's move on to another sort of fun disease, neuro-ophthalmic disease. And until recently, it wasn't that much fun for anybody. So myasthenia gravis. Autoimmune disorder characterized by weakness and fatigability of the skeletal muscles. So that's the muscles we control, basically. So muscle weakness due to dysfunction of the neuromuscular junction, all stuff we learned in optometry school and medical school. Remember that often patients will first present with ophthalmic presentations, ptosis, extraocular muscle disorder, of myasthenia gravis before they have the more generalized presentation. And so therefore, the blood test for acetylcholine receptor antibodies may not be positive in these individuals if they just have the ophthalmic presentation and not the generalized version yet. So myasthenia gravis, and we had just talked about that, 50% of patients will present with ocular symptoms first before they develop any generalized disease, which is usually occurs within 2 years of having the ophthalmic presentation. So you get weakness of the eyelid muscles, the levator especially, which leads to the ptosis. It's variable throughout the day, it gets worse as the day goes on in many cases. They can have this binocular diplopia. So when the patient covers one eye, it disappears, one eye or the other, it disappears. And a lot of times they'll have both of these issues going on at the same time. So you're going to check their eye movements to see if there's any weakness or so. Remember, in myasthenia gravis, they always beat that into our heads. The pupil is never involved. So if you have something like extraocular muscles and ptosis and a pupil involvement, then you know you're not dealing with myasthenia gravis. I used to do the tensilon or edrophonium chloride test all the time in the office on these patients, and it works really well. But then, over the years, you get a little bit lazier, I suppose, and busier, and so you try to come up with a quicker test. And really, this ice pack test, there's also a sleep test you can do, but I'm not going to send my patients off to sleep or anything. But this ice pack test is nice because we have a refrigerator in the break room, and we have you have ice there, and you can put it together, and you apply it to the patient's eyelids, so with their eyes closed. You do it for 2 minutes, and basically before you do that, you measure their margin reflex distance 1, you measure their apertures essentially, and then you apply the ice test, you remove it after 2 minutes, and you remeasure them. And if they have an improvement in their ptosis, then that technically is positive for myasthenia gravis. The test does not work for the strabismus aspect of the extraocular muscle weakness part. It only works for the ptosis part. So if there's an improvement, then good chance they have myasthenia gravis. If there isn't, it doesn't mean they don't have it, but a positive test, I guess, is a good sign that you're heading in the right direction. You got probably the right diagnosis. So here's one of my patients. His right eye is affected more than his left. He's trying to look up. You can see he's got the ptosis, and then I'm just using the, checking his extraocular muscle motility. You can see the weakness. Medial rectus is hardly working. Lateral rectus isn't working. Inferior, superior, he's got everything. So this gentleman, has ptosis and strabismus, diplopia, and he's sort of a miserable. He's a nice guy, but he's miserable from the disease. He's not miserable. We've known about myasthenia for a long, long time, and there's been all kinds of different therapies available for it. Neostigmine, I still remember the pills we prescribed for that. It's an anticholinesterase, but it has all kinds of marked parasympathetic side effects. It doesn't work really well. Most people couldn't tolerate it. We always scan these with a chest CT to see if they have a possible thymoma. The thymus works in the autoimmune system. So if they did have any type of potential lesion there, we would remove the thymus, and hopefully that would quell their autoimmune disease. Some people even said remove the thymus even if there isn't any thymomas there. So, there's been a lot of back and forth on that. Steroids have been used consistently for this medication, and all kinds of different immune modulators that you could see listed below, including even plasmapheresis. But currently, there are 4 FDA-approved drugs for myasthenia gravis, which is, you know, how did he all of a sudden come up with 4? It's amazing. And one of them is one we're already familiar with. How about the eculizumab or Soliris? That one saw is one of the drugs that's approved for Devick's disease or neuromyelitis optica spectrum disorder. And it's that anti-C5 monoclonal antibody. And then the other one that I've seen advertised on television left and right is this Vyvgart or efgartigimod. Aha! Do you see? It's different. It's not a mAb. It's not a monoclonal antibody. Remember I said there is, we'll mention one of the mods out there too. So this is the first mod we're running across in neuro-ophthalmology. It's a different type of application here. So it's an IgG antibody fragment. Remember we talked about it's a fragment, and it inhibits the autoantibodies that destroy the acetylcholine receptors themselves. So if you spare the receptors, you get better muscle response. So that's essentially how it works. It's an infusion. It's that you do for 4 weeks, and then you wait a few months, and then you repeat, you know, depending on how the patient is responding. So theoretically, you could keep on using it indefinitely if you follow this type of guideline. And again, infection always seems to be the big issue. So that's 2 of the drugs. And then the other 2, the first one is ravulizumab. And this is the, I think it was last week or earlier this week was the first time I saw a TV commercial for this drug. So I've never seen one before, but they're advertising this one also. It's also an infusion drug. It's a C5 inhibitor. So it's a mAb. It's not a mod. And then the final one is this rozanolixizumab. I've never worked with this particular drug, but it is unique because it's also a monoclonal antibody, but it removes both the autoantibodies at the acetylcholine receptor site, but also the MuSK, which is the anti-muscle specific tyrosine kinase sites. So it's sort of has a dual action, and it has 92 to 95% effect on this generalized myasthenia gravis if they're positive for both of these. So it's an infusion pump that's administered subcutaneously. So the patient can't do it themselves. It still has to be sent in. And usually you have to give these drug holidays for about 8 weeks, and then you can restart the treatment cycle. So all of these drugs are, it's amazing that we have 4 of them for myasthenia gravis. So if one doesn't work, you can certainly try a different one on this patient. I'm most familiar with the eculizumab. I can't pronounce it, but I'm most familiar with this one. And that's because basically we've been using it for neuromyelitis optica spectrum disorder. So that's probably the one I'm the most familiar with.
Hey, Leo, I want to throw out a little comment here with Izervay, Iveric, and we see all this geographic atrophy being advertised on TV. That is going after the complement factor 5 in macular degeneration, but those aren't biologics. That's more of an aptamer that's out there. But since we're talking complement factor 5, it's really cool. These biologics are going after it for these kind of neurogenic conditions, but you might hear us as lecturers out there talking about complement factor 5 and macular degeneration. That's Izervay, but those aren't biologics that are being injected for geographic atrophy. I just wanted to kind of point out that's kind of like 3 times I've heard complement factor 5, and maybe there might be some confusion out there. I just wanted to clarify it.
Right, but it's still complement factor 5, you know, right?
Right.
So it's still the same. It's still the same. So there has to be an inflammatory component that they're still addressing with those other drugs.
Yep.
Okay. Good.
Perfect.
Yes,
Thank
I
you.
know. It's actually an exciting time in neuro-ophthalmology, because neuro-ophthalmology has always been like the unattractive sister or daughter or whatever son that nobody wants to date because you didn't do very much with it, and type of thing. But now there's just amazing what's available for neuro-ophthalmologists to work with and diagnose and make more specific diagnosis and treat. It's a very exciting time, I think, and plus it gives me all these new lectures to do.
Well, there you go.
So now we're going to talk about blepharoptosis. Now you're going to say blepharoptosis, now that's oculoplastics, right? Well, I mean, we know that there's lid issues involved in neurologic diseases too. So droopy eyelids could be congenital. So the lower left image here, you could see they're usually unilateral. It's in a younger child. And if you have an older individual, those are usually acquired for some reasons. The most common is this levator muscle dehiscence or disinsertion. So that's the usual involutional ptosis that we see. But like I said, don't forget the neurologic diseases. Horner syndrome can give you a ptosis. Remember, ptosis, meiosis, anhidrosis. Third nerve palsy certainly gives you a ptosis, a blown pupil, and usually a down and out type of presentation, extraocular muscles. And myasthenia gravis, where of course the pupil is never involved, and we've already discussed those. So how do we work up blepharoptosis? I do eyelid lifts all the time in the office, blepharoplasties. And so I'm always measuring for blepharoptosis to see if that's one of the components, if it's just dermatochalasis, if there's brow ptosis involved and stuff. But for blepharoptosis, I always measure the margin reflex distance 1, and that is the image here on the left. So basically, you're measuring in millimeters from the central reflex from the penlight or fin-off transilluminator you're shining to the upper eyelid margin, essentially, and how many millimeters that is, and you're comparing the two, and you want to make sure that what the amount is. Levator function is another thing that we do, and basically here I use my hand to basically secure the frontalis muscle so they can't use their frontalis or their eyebrow, and then I have the patient look without moving their head all the way down as far as they can. And that's your baseline. And then while you keep the millimeter ruler exactly the same, and again, you sort of don't let them move their head, you ask them to look up as far as they can, and you see the excursion in millimeters from the inferior most to the superior most view. So here it's basically about 13, 14 or so millimeters. And basically that's in the normal range. The other thing is, for insurance reasons, if I'm going to do a blepharoplasty or a ptosis repair, I'm going to wind up also doing visual fields, taped and untaped. And usually we have to show that it's at least like 15 degrees or so visual field, superior visual field improvement for the insurance companies like Medicare and others to compensate for the surgery, to actually approve it and then pay for it. So the surgeries are either levator resection, if they have like true ptosis from levator superior, the levator muscle itself. If the Mueller's muscle is involved, remember Mueller's muscle is sympathetic and it elevates the eyelid an additional couple millimeters or so. We could just do a specific conjunctival resection. And if both of these are involved and they really have minimal to no lift, you can do what's called a frontalis sling, which essentially you connect the eyelid up to the frontalis musculature. And then if the patient wants to lift their eyelid, they elevate their eyebrow, they initiate the action of the levator muscle, and that pulls up the eyelid for them. But we also have this new medication, and hopefully all of you have had a chance to try this clinically on a patient. I've been using it on my patients. It's known as oxymetazoline, 0.1%, known as Upneeq. And it's the first FDA-approved drug for the medical treatment of acquired ptosis in adults. It hasn't been, we're not using it in kids at this point. So it stimulates the alpha adrenergic receptors of the Mueller's muscle. So that's why you're only getting about 1 to maybe 2 millimeters of lift in this particular, when you're using this particular medication. And it's the same component that's found in Afrin and Visine. It's supposed to last 6 or more hours. I've used it in patients who don't want to have ptosis surgery. And so they'll come in and we'll put them on this medication. They usually wind up using it only if they go out to socialize for the day, or or go to church or something like that. So they don't use it if they're just sitting around at home in most cases. Off-label, I do a lot of botulinum toxin injections for hemifacial spasm, benign essential blepharospasm, Mies syndrome, things like that. And sometimes you give them an injection, it's the same you've given before, but the medication may migrate more posteriorly from the orbicularis, may migrate more to the levator, and then this patient has a mild or moderate type induced ptosis from the Botox injection. And so for the couple weeks that it's sort of persisting, I'll put them on the Upneeq, and usually that's sufficient. So they're not mad at you, because there's really no way to reverse the Botox injection anyway. It has to sort of wear off on its own. And I found that this works pretty well and it placates the patient. If the patient has had Graves' disease, the eyelid, thyroid eye disease, and there's a slight asymmetry between the lids, they can use this also to sort of even them up when they're out, so that cosmetically they look a little bit more normal. This is from the company itself that makes the Upneeq. You could see that it works for mild, moderate, and severe. And, there really is, it's interesting. There is a definite improvement in these patients that use this medication. And I've had pretty good success with it. Side effects, adverse effects are minimal. Most of the time, it's just irritation or dry eye type symptoms. The theoretical ones are tachyphylaxis, because, if you're using Visine constantly, you need to use it more often, more frequently to get the red out. I mean, can you get tachyphylaxis? I haven't seen that in my patients, because they sort of use it more sparingly. So that may be the reason. If they have some dry eye, could that induce Sjogren's syndrome? There's been some literature about that. I haven't seen that. And how about if they have narrow angle? Can that induce angle closure in these patients? And, so maybe it's worth looking at the patient and make sure they don't have a narrow angle before you try this medication. Or if they do have narrow angles, you may want to consider, I do laser peripheral iridotomies. You want to send them for maybe an LPI to have done if you were going to consider using this medication. So there are some relative contraindications to using this medication. Obviously, if they have uncontrolled hypertension or coronary, cerebral, or cardiovascular disease or something like that, you should be careful about putting an alpha adrenergic in their system. I've not had any patients that had anything that was severe enough or uncontrolled hypertension where I wasn't able to use this medication successfully on them. We have polling test question number 4.
Yep, and I have it open, so you're not going to see it pop up for those that were making the comments in the chat box. The polling question is open, and it is: blepharoptosis can be defined as retracted eyelids, droopy eyebrows, lid lag on upgaze, droopy eyelids. And I see people responding, so I know that it's open. So, Leah, I was looking at the chat box. Looks like you're all caught up on the questions there. I still use Upneeq. It's kind of a bummer that it didn't take off. They lost a lot of their sales force, so on and so forth. But, for that right person that's out there, like you said, that asymmetric, they use it occasionally. It opens up their fields. I think it's a good, not a great medication, but a good medication, and Too bad it didn't really catch on too well.
Yeah, I find that I have a lot of older patients that have some of this involutional ptosis. It's not terrible, but they notice it, and they, sometimes it may affect their driving, things like that. And when you start talking surgery to them, it's like, yeah, I don't want to have surgery. And so this is for me, it's a good option. And the thing is, I usually will put some in the office in their eye, and then I'll have them sit around for a while, and I have them look in the mirror before and after, and they usually are pretty satisfied, and they use it sparingly. They'll use it when they need it, and that's why I think I'm not seeing any tachyphylaxis with it, because I don't think I have anybody that's using it every day consistently. So they're sort of monitoring themselves. I did not know about the sales force, being cut and all that. That's always a bad sign. Hopefully they don't take it off the market.
Yep, I agree. And then the lecturing with the pharmacist that I lecture with, you had that slide where about the hypertension and all that. And she basically said that, anytime you have an alpha adrenergic, whether it's oral, systemic, IV, eye drop, they're just going to throw that on there automatically. But she felt that it was pretty safe medication when you're using one drop in each eye, that you're probably not going to trigger too much. It just kind of gets thrown on there. But I think we still have to be careful, like you mentioned, but that's kind of how that all ends up on there on those package inserts. So, all right.
I think it's reasonable.
So here we go. We got your polling question. Again, they're still paying attention. You got 84% saying droopy eyelids, and then kind of a little smatter of 3% down to 10% calling out the other ones: retracted eyelids, droopy eyebrows, and lid lag. So very good.
Yeah, I tried to make that one simple, because I said droopy eyelids when I started. Mm-hmm. All right, so we're sort of getting to the tail end of my presentation here, and I'm gonna sort of deviate here a little bit into my osteopathic degree, and we'll sort of address it, although it relates to the optique also. We'll do a case here. So I had this 38-year-old Hispanic female who came to see me, and she's very in tune with her presentation and her looks and things like that. And she's very concerned that she has this right eyebrow swelling and this eyelid drooping. When I evaluated, I could see that the eyelid drooping, the right upper eyelid drooping ptosis, was not really a real ptosis. It was a mechanical ptosis where the eyebrow swelling was actually sort of pushing the lid down mechanically. Although, she thought it was she was more concerned about her eyelid droop than the swelling, although I could tell that there was some asymmetry there. So she had even had a CT scan done through the emergency room. And so, of course, I went ahead and had to order something too. So I ordered an MRI. And you're saying, well, I want to make sure there's no tumor back there. There's no lacrimal gland enlargement, something, that there's stuff up there, and it's worth taking a look. And MRI is usually better for soft tissue imaging anyway. Could it be thyroid disease? I did TSH, T3, T4. So I did a thyroid panel on her, worked her up. Could it be myasthenia gravis? I doubt it, but I went ahead and did the ICE test just so as to verify in my own mind it was negative. Then I did some other sporadic tests on blood tests on her, including sarcoid, because sarcoid can, in a younger female like this, can infiltrate the lacrimal gland, and it can cause problems and presentation like this too. So sarcoid and some other blood tests I did on her, but otherwise she was really pretty healthy. And so I told her, I think that doing ptosis repair on you is not the right way to go, because I think you have mechanical ptosis, so you have this swelling, and it really is, trying to do eyelid surgery is not right. But she really pretty insistent. She just didn't like the asymmetry that she had. So I did try optique on her, and she actually worked pretty well. It lifted her lid up and made it much more symmetric, and made her notice that she now has eyebrow ptosis, that she has eyebrow swelling. So before she was sort of fixed on the eyelid ptosis, and when I fixed it with the up knee, then she started saying, well, you're right. My eyebrow is swollen on this side. Now you have to fix that for me. So, how do you fix eyebrow swelling? Well, luckily, I am a DO, ophthalmologist, DO. So we were taught osteopathic manipulation, and part of the manipulative system that we work with is the lymphatics. Now, we all know we have lymphatics, and nobody ever seems to talk much about it. The only thing I remember anything about lymphatics in optometry school was when they talked to us about palpating for preauricular nodes, which is great. That's a very valid thing to check for if you think they have, viral, cat scratch disease or something like that. That's perfectly fine. And even in medical school, lymphatics were more dealing with cancer and things like that. But osteopathic medicine looks at lymphatics a little bit differently in regards to that it's another of the systems besides the arteries and the veins. And we address arteries and veins all day long, but we don't really address lymphatics. And there are manipulative techniques for that. So I thought, I'm really running out of things to do on this lady. I don't want to get another MRI. So let me pull out my osteopathic hat, and I do osteopathic manipulation for various things also in my office if they're ophthalmic related. And so I set up this program for her in regards to, of what testing I'm going to do on her to see if I could address the eyebrow swelling. In my mind, I was thinking, well, maybe it's a lymphatic issue. There's some backup, and that's why she's got that swelling there. And if I can relieve the swelling, she doesn't even have to use up knee because her ptosis will also miraculously go away. So I'm going to talk to you a little bit about what I did. So I did address the lymphatics, and the theory in osteopathic medicine, it's known as the rivers to oceans concept. So basically, if you want to drain a particular river, you have to start at the ocean to make sure there's no obstruction at the ocean, open up those obstructions, then work at the entrance of the river into the ocean, and you work your way up and try to eliminate any obstructions along the way. So basically it's release proximal to distal. So the oceans in osteopathic medicine is the right lymphatic duct and the thoracic duct, which is actually located on the left side. And there you would release or treat the fascia of the surrounding lymphatic ducts, which promotes the drainage of the lymphatics into the subclavian veins, basically. And the rivers are these upstream lymphatic vessels. So I address the ocean by doing two things: a thoracic outlet release, thoracic inlet release, and then the rivers, starting at the anterior cervical, working my way up the cervicals and working my way up to the lymphatic drainage of the face and the periorbital region. I'm not going to go through every single one of these, but I'm going to highlight the specific ones, and I have some videos.
The next procedure is a thoracic inlet release technique, and this is for the treatment of the fascia surrounding the lymphatic ducts. The patient should be in a supine position and their arm at 90 degrees to the body. You should sit on the same side as the patient. Always begin on the left side because the majority of the lymph flows through the thoracic duct. The knee supports the patient's elbow, your cephalad hand supporting the patient's wrist, and the caudal fingers placed on the superior aspect of the supraclavicular fossa. You're applying a downward pressure to the patient's wrist as the caudal fingers begin to wrap around the clavicle, applying gentle pressure around the clavicle. Then you're going to move the wrist back into the standard 90 degree position, and the caudal hand will follow the rotation of the clavicle posteriorly as you repeat the maneuver until tension develops. Hold this for some relaxation is noted, and this can be repeated several times as necessary. And when the left side is completed, you can move to the right side to do the right lymphatic duct.
So this is one of the two techniques that I apply to the patient that basically opens up the oceans for them. So where everything else is going to enter. And now I'm going to...
The next procedure is the cervical lymph drainage technique, and this specifically addresses the jugular lymphatic chains. Again, the patient is supine and you are seated at the head of the patient. You need to identify the sternocleidoid mastoid muscle one more time. And as before, we're working from proximal to distal. So we're going to address the inferior aspect of the muscle. On the anterior border, you'll place your thumb and you'll gently stroke inferiorly along the sternocleidoid mastoid muscle border towards its insertion at the sternum and the clavicle. The next step is to move to the medial aspect of the sternocleidoid muscle and again gently massage along the anterior border. And finally, you're going to go to the most superior aspect of the sternocleidoid mastoid muscle, and again, in a very gentle fashion, just massage along the anterior border. And then you'll repeat the procedure again, but this time starting at the posterior border of the sternocleidoid mastoid muscle. Then you'll go to the medial aspect.
I meant middle.
Gently massage, and then finally finish in the superior-most aspect. You should repeat the total sequence 3 times, both anterior border and posterior border.
So here, what you're noticing is I've opened up the thoracic ducts, basically any blockage there. And now I'm working on the cervicals, and what I'm doing is I'm just milking the lymphatic channels and getting the lymphatics to drain from proximal to distal is where I'm working, but I'm having them drain from more distal into the more proximal thoracics. And then we're going to finish off, if I can click this, with the face.
The next technique is the lymphatic drainage of the face. I usually use both my thumbs, although one can use all their fingers for this maneuver also. You start off over the frontal sinus area and you gently massage in an effleurage-like technique along the temple area and then down towards the mandible. So you would start over the frontal area, go laterally onto the temple area, and then down towards the mandible. To do the same procedure on the maxillary sinus, you would place your thumbs over the maxilla, go laterally in the area of the preauricular nodes, and then down to the mandible. Maxillary area laterally. Make sure you get the preauricular nodes, and then down towards the mandible. And you can alternate this between the two sides.
So basically here I'm working the face, and again I'm massaging, basically getting the lymphatics to flow into through the cervicals and then down into the thoracics. And I actually did this for this patient, And I did several sessions. She returned on several sessions, and it actually did help to minimize the amount of eyebrow edema that she had, to the point that she was able to stop using even the upneek because her ptosis, there was no mechanical traction on the eyelid anymore. And so basically, I was able to help her with this. I don't know what caused it, but I certainly was able to address it to the point that she was satisfied enough that she no longer needed to pursue any type of surgery. Whoops, I don't want to end the show.
The next technique is the lymphatic drainage of the face. I usually use both my thumbs, although one can
Student, go up to the top and hit next.
all their fingers for this maneuver.
Oh, okay.
All the way up, go next.
Oh, yeah, thank you. Okay, thank you. There is actually a coding for this. So I did 3 regions, head, cervical, and thoracic. So I was able to use one of the osteopathic manipulation codes. Now, MDs use these codes. I know that family medicine doctors use these codes. I know that PTs, OTs, nurse practitioners, if they're working in orthopedics and things like that, can use these codes. I don't know if optometrists can use these codes. You have to check with your state association. But if you were to start using manipulation, there's all kinds of different ophthalmic osteopathic manipulation techniques. You may be able to not only help your patient in a unique, holistic type of way, but also be able to code for it. So we're going to wrap this up here because I'm running out of time. So we're going to talk just a second about dry eye. Dry eye, now where does that come in from neuro-ophthalmology? And it sort of comes in because there's a drug out there called varenicline, Tyrvaya, that basically is a nasal spray. It works by as a cholinergic agonist that neuroactivates the trigeminal nerve, providing parasympathetic stimulation to the entire lacrimal functional unit, which we know produces the basal tear production, essentially. So it's basically works in a neurologic fashion. You inject it both nostrils twice a day. Sneezing is the biggest complication people have, or cough if it goes down the back of the throat. But I just wanted to mention that this is not a new concept. There is an osteopathic technique known as sphenopalatine ganglion release. And if you look at this, it works by the postganglionic fibers from the sphenopalatine ganglion supply the parasympathetic innervation, exactly what gets neurostimulated by Tyrvaya. And so it stimulates the lacrimal gland to produce this reflexive lacrimation. And this is a very simple technique. I do this on my patients who have dry eye. As you know, these are some of the toughest patients sometimes to take care of. And I teach them how to do it themselves so that they can go home and do it themselves. I always wear a glove, of course, when I do it on a patient. But basically, you use your little finger, your 5th digit, and you just manually massage, press on the sphenopalatine ganglion, which is located in the superior, posterior, and lateral pharynx. And trust me, if you do this on yourself and you find the right spot and you sort of push and massage on that, you're going to get a welling up of tears in both your eyes. So I'm not saying that this is in lieu of Tyrvaya or anything else that you're using in dry eye, but I think this may be an adjunct that you can add to your repertoire, not only to treat the patient in your office, but teach them how they could use it themselves if they're in a situation where they're don't have the medication with them or so, and they can actually stimulate their own glands. Now, you're going to tell me, I promise I'm going to be done here in a moment, you're going to tell me, you're going to say, well, this is all beyond what optometrists do or know anything about. And I'm going to tell you right now that all optometrists that are listening to this have been taught manual medicine. That's what MDs call osteopathic medicine. They call it manual medicine. You've all already been taught this in optometry school. I know because I've been taught this in optometry school. And many of you are probably already doing manual medicine in your office and probably teaching patients to go home and do manual medicine techniques on your patients. And I'm going to show you right now the one I'm talking about. Or maybe before we get to that, we need to do
just skip the
poll
poll
question
for time's sake. Go ahead. You can just skip that.
Okay, sorry.
No worries.
And here it is. Have you ever heard of the Kriegler maneuver? And I'm going to tell you, every single one of you know this. Maybe you don't know the name, but it's hydrostatic massage that we use for congenital dacryostenosis. As we know that 20% of newborns can be born with this non-patent valve of Hasner, the parents bring these kids in for us to see, and we try this hydrostatic massage. We teach the patients, parents how to do it. They do it. So you see, this is actually manual medicine. We call it manual medicine because Kriegler was an MD who came up with this massage technique back in the 1920s. So it's not really an osteopathic technique, but it's something you're doing already. You're already doing manual medicine. And dry eye is so ubiquitous, that's probably the easiest, I think, of all the osteopathic techniques that you could try adding to your practice if you have such a desire. So I am going to click my last slide. Ta-da. And are there any questions?
I have a comment from an audience member or from an attendee that basically said their daughter's attending osteopathic school and manipulation is helping her refractive shoulder. So that's a comment that's out there. Just giving you a little kudos there. I have a question on when people come in and they have these lymphatic cysts, conjunctival lymphatic cysts, would manipulation help those starting with, like how you said, and moving away?
That is a wonderful question, and I am embarrassed to tell you I have never thought of using manipulation for those cysts. I have, I am a surgeon. For me, it's just easier to excise them. But if I have a patient that's resistant to surgery, I have not, to excise one of them. That is, I would certainly consider trying it. I don't know if it would work or not, but, I didn't know that this lady's situation that I use as a case report would work or not either. But, I didn't want to do surgery on her personally because I thought that was the wrong approach. And so I'm glad it did work for her. But I don't know. I mean, that's we should do some sort of study. That would be sort of, I think, cool.
I think that'd be kind of neat. So I'm going to take over. I'm going to share here my screen again. And I want to say thank you for doing this. All the questions have been caught up. Joe, do you have any comments before we wrap up the education?
I thought it was fantastic. I always enjoyed neuro-op. So this was especially interesting for me. So thank you, Lou. We really appreciate you doing this for us.
Not at all. I'm happy to do it, and I like talking about neuro-op because it's people are all afraid of it, and I just want to make it so that people are less afraid of it.
Yeah, I think you kind of summarized it kind of throughout the talk there is that, before it was, okay, we didn't really have much to do, but now there's lots of cool things. And with the limitation of the neuro-ophthalmologist out there, between you and Joe and Len Mesner and Andy Lee, you're certainly making optometry more and more comfortable with this because we're going to have to be doing a lot of this because it's hard to get in to see a neuro-ophthalmologist. So I appreciate you doing it.
I mean, there are states out there that don't even have a single neuro-ophthalmologist in the whole state.
Yep. Well, you're over here in the chat box. I mean, you can't see it, but you're getting your virtual round of applause. Thank you so much. I'm going to end
I want to thank everybody. Yes, thank you.
Yep. So I'm going to end the education here, and again, thank you for doing this.
You're welcome. Have a good night.
Thank you, Leo.
All right.